Good afternoon. My name is Dr. Tibor Racz. I am a private pain physician here in the Dallas area, practicing interventional pain management. I trained at the Texas Tech Pain Center as a fellow and have been asked to discuss trigeminal neuralgia and its treatment here today. So the history of trigeminal block is about in the early 1900s. They started doing blocking the trigeminal ganglion in Meckel's cavity, and this they was initially just treated with blocks, but they developed it into neurolytic techniques with both phenol and alcohol, and even in the 1930s they started radiofrequency heat lesioning treatments. Other advancements in therapy for this kind of problem has been balloon decompressions and surgical options as well. Sometimes the problem can be directly related to compression. There can be other causes, idiopathic causes, even multiple sclerosis. And initial treatment, conservative treatment for something like this is medication management or therapies. But at some point, interventional therapy may be indicated. Another case in which this would be an optimal treatment option is for those with trigeminal neuralgia related to some cancer scenario of the head and neck. So the trigeminal nerve comes out of the base of the skull into Meckel's cave. And the trigeminal nerve actually branches off into three branches: the ophthalmic, the maxillary, and the mandibular branches. The ophthalmic and maxillary branches are a little bit more medial in the cave, in the cavern, whereas the mandibular branch lies a little more laterally. As well as the ophthalmic branch is more dorsal in the cavity, the maxillary branch is more medial, or in the middle, and the mandibular branch lies more ventrally. And that helps to try to guide treatment if you're trying to specifically get one branch, whether the pain is more in the maxillary area or ophthalmic or mandibular. Usually there can be some discomfort with this procedure, and so we like to do ours with sedation, with an anesthetist who's providing sedation with Versed, fentanyl, in some cases a little propofol if indicated, depending on the preference of the pain management physician. Traditionally, people use like a 22 gauge spinal needle, but in my training, we were taught to use a blunt tip approach, and so I use a short catheter access needle to break the skin and minimize the risk of infection and possibly meningitis. And then taking out the stylet, insert a blunt 22 gauge needle. I prefer having a curve on the end to be able to be more specific with placement once into the foramen ovale. The skin is prepped sterilely, and direct fluoroscopy is used with the patient in the supine position, starting out with an AP view of the fluoroscopy. The technique for landmarks is to approach the skin roughly 2 to 3 centimeters lateral to the curve of the mouth, and in the lateral view it's about 3 centimeters in front of the external meatus of the ear. Using fluoroscopy, I take the angle of the scope and come about 30 degrees laterally, and then another 30 degrees roughly with a submental oblique approach, and that gives us optimization of visualization of the foramen ovale. The needle I use the blunt access needle to break the skin and advance down. You can place your finger on the inside of the mouth if needed to ensure that you don't break the mucosa. Once in the superficial tissue, the sharp stylet is removed, and I use the blunt curved needle to advance down directly to the foramen ovale with a gun barrel technique. Once I am at the entrance to the foramen ovale, I confirm placement at that point. Once I'm happy with the angle, as I'm angling towards the eye and the AP view, we go down until we're entered right into the lateral view, confirming placement of the foramen ovale. At this point, I would then put in about a quarter to half cc of contrast to confirm placement and filling of the Meckel's cave. If I was specifically trying to target more of the mandibular branch versus ophthalmic, I would be curved towards the ventromedial side. At this point, after confirmation of placement of the needle, I would inject the local anesthetic, either 0.25% Marcaine or possibly 0.2% ropivacaine, mixed with possibly a little steroids, such as 40 milligrams of depomedrol. Another option for a neurolytic technique would be to inject phenol or alcohol. And then another option, again, would be to proceed with radiofrequency if it is not a diagnostic block. Complications of this procedure are including bleeding, infection, and nerve damage. Specifically, we worry about retrobulbar hemorrhage, blunting of the corneal reflex, carotid injury. We specifically want to use sterile technique to avoid any risk of infection with possibly meningitis being so close to the brain. We also try to minimize risk of bleeding in general using a blunt tip catheter or needle technique. So especially in a case like this, where you have a needle doing a complicated procedure close to the brainstem, close to the nerves of the face, we really want to minimize any risk of bleeding. And the best way to do that is to use excellent technique, adequate sedation, but also a blunt needle minimizes trauma and injury to nerves. An example of a patient who responded well to trigeminal ganglion block would be a patient of mine who was diagnosed with cancer, had intractable facial pain, had been treated with opioids and neurolytic, neuropathic medications without any success, with pain that was coming across the face, the cheek, and into the jaw. Patient had been treated by a previous pain physician and had even sphenopalatine block, so we had decided to proceed with a diagnostic trigeminal block. Patient underwent the procedure uneventfully using 0.25% Marcaine and injecting with a little bit of steroid. Patient got excellent relief for the first time in months that lasted for about a week. Decision was made to bring the patient back for a repeat injection, and again got wonderful results that only lasted for about a week. Therefore, decision was made to proceed with radiofrequency. Patient underwent radiofrequency under sedation with a blunt coude needle, RF needle, and successfully got improvement in their symptoms. Not 100%, but enough to control it in combination with the medications. Treatment of intractable trigeminal neuralgia can be challenging, but with proper technique and preparation and knowledge of anatomy and using the right equipment and needles, a trigeminal ganglion block is a simple and quick outpatient procedure that can give a lot of relief for a very difficult, complex pain syndrome.